buy you a reasonable amount of time after medical therapy has come to an end, so that your valvular heart disease can be managed for a longer period of time without having a heart failure. So this is a very interesting map. This is from the 2025 guidelines of the American Heart Association valvular heart disease guidelines. So if you predominantly look at, I will just take pointer. Yeah. So if you predominantly look at Sub-Saharan Africa, so you would see the prevalence of rheumatic heart disease somewhere more than 1,000 per million population. But the same as you move northward, or kind of the Middle East, North Africa region is quite less in countries like Libya, Egypt, Algeria, Morocco. If you move to the continental Europe and to the United States, Canada, you see they're again quite less. They're again in the blue zone in terms of rheumatic heart disease prevalence. And well, the global prevalence is somewhere around 55 per million population. The same thing in parts of Latin America, in parts of southern regions of Africa or Sub-Saharan Africa, are more than 1,000 per million population. Um, which does not mean that congenitally people in Africa have bad valves. Just means that people do not have access to good quality healthcare, or people may not be having access to good quality antibiotics or community surveillance programs, which is the reason why rheumatic heart disease is affecting people in Africa as much. If you look at the next slide, which is basically the calcific valvular disease, you could see the calcific valvular disease incidence is somewhat lowest among people in Africa. So it's not that people in Africa have genetically bad valves. It is that kids get these infections, acute rheumatic fever, streptococcal, group B streptococci infections in their throat, and that is causing this havoc in terms of the rheumatic heart disease prevalence and burden. The incidence of calcific valvular disease in some parts of Africa, they're even less than the global standard of 13.3. They are, at times less than, in the range of 0 to 10 per million population. Whereas if you go to the developed world, where people are consuming fatty food, high caloric food, continental Europe, Russia, the former Soviet countries, Canada, New Zealand, parts of Latin America, you can see that the prevalence is quite high. They're almost in hundreds, 200 plus in these regions that are in red. Coming to the next, which would be the mitral valvular heart disease. You would again see that the degenerative mitral valvular heart disease is again more in the Caucasian population, in continental America, Europe, parts of Russia, Latin America, whereas in Africa it is one of the lowest, which goes on to show a very basic premise that we should understand, is that Africans are not genetically or racially predisposed to have valvular heart disease. It is only primarily the socioeconomic factor which makes rheumatic heart disease such a huge problem. I mean, almost 20 times the burden of rheumatic heart disease. I mean, almost 1,000 plus in place of 55 per million population. What is the global standard? In Africa, it is about 1,000 plus, and you can see it's almost pan African, barring maybe a few countries in the North African region. Coming to what are the primary causes of valvular heart disease in the Asia Pacific region, which is another emerging region. So most common would be rheumatic heart disease, which is still reasonably prevalent in low to middle income countries, in certain pockets of India, in certain Southeast Asian countries, in certain island nations in the Pacific. Um, Also, the Asia Pacific population, or kind of the indigenous population of the island nations, are more prone to having this bicuspid aortic stenosis. Whereas aortic regurgitation seems to be more common in continental America, Europe, among these traditional Caucasian population, the Asia Pacific population seems to have more of this bicuspid aortic valve disease. Um, Another common challenge is that these people have a smaller body habitus, so they have small aortic annuluses, small mitral valve areas, and which are more prone to, getting stenosed quickly rather than the big aortic and the mitral valves as found in the Caucasian population. Late diagnosis and a significant disparity in access to valvular interventions and valvular heart disease care, I would say even more than intervention, it would basically be access to quality valvular disease care. Um, More commonly, the regurgitant lesions are quite ignored in this part of the world for the simple fact that we believe that the regurgitant lesions are going to, take a longer time or have a longer natural history to progress to a severe valvular disease. And by the time they present to the clinic, they're already in kind of decompensated heart failure owing to structural anomalies, which could have been completely prevented had he or she turned up to a clinic maybe 10, 15 years ago. The tendency of degenerative valvular disease, which is more in the West, is also growing in Asia Pacific now because the average life expectancy of people are kind of climbing to the high 60s and 70s, which was not the case maybe 20, 25 years back. Um, so the real challenges, if I had to point them out, would be limited access to diagnostic technology, excessive costs, quality echocardiogram, somewhere in Africa, as per an UN report, would cost somewhere around 250 US dollar, where the average monthly income of a person in Sub-Saharan Africa is just about $150. So if it means that you need to spend 2 months worth of your wage just to get an echocardiogram, that echocardiogram is not a reality but a distant dream. So that thing has changed. Echocardiography remains the gold standard, but there is severe shortage of echocardiography machines, trained echocardiography technicians, prohibitive costs. So all of these makes echocardiography a shortage. But the other thing that I would like to say very personally would be, I see a reasonable amount of people from Africa trying to report their valvular heart disease. They would at times come up with an echocardiogram, but that echocardiogram would be more often than not very non-standard. A standard echocardiogram talks in terms of the American Heart Association classification of ABC, or it would talk in terms of specific echocardiographic markers for stenotic lesions. It will be speaking about orifice areas, it will be talking about pressure off times, and for regurgitant lesion, it will be talking about the jet surface area or the vena contracta. These are very haphazard, echocardiographic interpretations, atrioventricular valvular regurgitations being more often than not very haphazardly, mitral tricuspid being very haphazardly claimed as mild mitral or mild tricuspid regurgitation with hypertensive heart disease. God knows where the term comes from. Hypertensive heart is that is such a that
Hi,
is such a
hi, 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 Dr. Biswarup. Sorry to interrupt, but if we could go a little bit slow, sir.
okay.
Sometimes
I'm
when
sorry.
you're, I mean,
I'm
fast.
sorry. I'm sorry about that. I'll try to explain it.
Okay.
So a lot of echocardiography reports that come to me from Africa will have very non-standard reporting parameters. So if we are talking of stenotic lesions, whether it is mitral stenosis or aortic stenosis, we ought to be talking about numbers like orifice area, orifice area indexed to the body surface area. We ought to be talking about pressure half time. We have to be talking about pressure gradients. We have to be talking about the flow restriction. We have to be talking about the overall hemodynamics of the patient. Whereas these are often reported as mild mitral stenosis with hypertensive heart disease. Makes no sense. Similar for regurgitant lesions, if you're talking about mitral aortic or tricuspid regurgitant lesions, hypertensive heart disease or bulky heart, those kind of terms have very minimal significance when you're trying to read a report and make a sense of it. So it has to talk about the jet surface area. It has to talk about the vena contracta, which is the narrowest part of your regurgitant lesion, or kind of the nearest part of the cone. You have to be talking about pressure half times. You have to be talking about the flow dynamics. You have to be talking about their significance or their percentages or their numbers or the specific guidelines. You ought to be talking about the valvular heart disease in terms of the American Heart Association classification of A, B, C, you know, at risk, progressive, progressed. So we have to be talking about these terms, these numbers, these values when we are reporting echocardiography. The other thing is obviously geographic barriers. There are some urban centers that I understand are there in Africa which are doing a reasonable job, but then there are a lot of people who live so far away, or there are such geographic barriers living in rural communities that they have little to no access to these few facilities that exist. So limited access to diagnostics, extremely high cost, um, non-standard echocardiography, and geographic barrier would probably be the reasons for limited access to good diagnostics in diagnosing, identifying, and then it comes to treating the valvular heart disease. Um, into the next slide. So the gaps basically can be classified as infrastructure and workforce gaps. So there is a severe lack of specialist care. There will not be a qualified specialist per million population, or there will not be a qualified specialist for a specific designated territory. There is a lack of primary care facilities as well in these areas. At times, the nurses or general practitioners will not be very aware of when do we need to intervene, what do we need to do, how do we need to communicate this problem to other people, or to referring physicians, or to referring teams. What do we need to inform them? So these are very important. The general practitioners, the community nurses have to give us a valvular heart disease um, problem cannot start with a report of electrolyte, followed by a blood gas, followed by a CBC count, followed by a urine analysis. At the very end, a small clinic note. So the general practitioners, the nurses, they have to do due diligence, give us a good reference note, supplement to the same with a good echocardiography finding, supplement the same with some stark blood workup findings that are there, and that should be all. I am not very keen to know what was that person's potassium or phosphate on a given morning. That is quite, I mean, that might be significant to his care in the ICU, but that is quite insignificant when I'm trying to help his valvular heart disease as a specialist. So the referrals have to come organized, and this can only happen when the nurses and the general practitioners are primed as to how they should report these problems to their colleagues or other medical colleagues who are trying to help them out. And last but not the least would be a lack of testing facilities, inadequate amount of labs that can process microbiological and other samples to identify the streptococcal infections, or to identify other blood workups that are quite essential for monitoring these people who are in heart failure due to valvular heart disease. They need to have a sixth monthly investigation like brain natriuretic peptide, their CRP levels. They need to have their kidney functions checked because they are on diuretics more often than not. They have to see the liver functions test to understand their blood coagulation profile, and they need to have an overall blood workup to see that there is nothing gross that we are missing. So these are things that needs to be done for every valvular heart patient once in 6 months. That is another problem. I would be seeing patients in 2026 with reports dating back to say October of 2024. They're quite irrelevant, to put it frankly. Um, Now that we understand the infrastructure and the workforce gaps, comes the timing of the presentation of the disease. So these valvular disease initially will present with a very indolent, silent course. They're asymptomatic for the longest period of time. And if there is not a very robust screening program, you will not be able to catch them on time. And when they present to us, they're decompensated heart failure. They're not able to walk. They're not able to breathe. They are on very high doses of diuretics. They are limited in their fluid intake. So a lot of things must have gone wrong with them while they were waiting in the community as sitting ducks, unaware of their problem, unaware of their malady, unaware of their valvular disease, which has progressed quite a bit. It is also not uncommon to see young mothers in their second or third pregnancy, when there is a huge volume overload situation in the body, present to us with histories often noting that there has been uncomplicated pregnancies in the past, but the current pregnancy has been more complicated because of the presence of this valvular disease. So, unlike in the Western countries where it is mostly a degenerative disease of the old, in the East, in Asia, in Africa, in Asia Pacific region. This is primarily a disease of the younger population because rheumatic heart disease is much more prevalent in this part of the world, and they are also more, often than not affecting children as well as young adults. So younger population, silent progression, and severe complications of because of the existing of the disease itself. By the time they get access to good quality healthcare, they are diagnosed. They have now by now ended up in an advanced, decompensated, almost non-reversible heart failure. So what do we do with them? There have been patients that I have seen started with a rheumatic heart disease some 10 years back, now ends up with such a severe left heart failure that you ought to put these patients on mechanical circulatory supports or support them or supplant them with LVADs and list them up for transplants. So that timing, the severity, and the age of the population also makes difference as to how we guide the management of the disease. Socioeconomic barriers, as I said earlier, the rheumatic heart disease prevalence is only owing to socioeconomic barriers and challenges that we face. So it's poverty, overcrowding, many people staying together, poor sanitation and hygiene, ideal breeding factors for streptococcal organisms to cause sore throat in children. Lack of literacy again means lack of awareness, lack of understanding that yes, we need to tackle this problem as seriously as we're tackling maybe diabetes or coronary artery disease. Valvular heart disease in the emerging world is as big a killer, if not more, in comparison to coronary artery disease. So this is the whole cycle of the valvular heart disease patient. So today we are employing artificial intelligence to make this valvular heart disease diagnosis in the community. We are using certain genomic and genetic modifications and markers to see if these people are more genetically prone to developing this. We are making specific forum for similar types of patients with similar problems clubbed together so that each other can act as a support group for the other patient. There are a lot of transcatheter therapies that has been in the market. Some of them are really good bailouts for any form of valvular heart disease, and I've gradually started becoming a believer in them. Though I initially was not. I thought catheter therapies are only for they just eyewash. They aren't. And lastly, the proof of concept studies and collaborations worldwide, along with superior teams, along with teams that are doing better than you, will always put you in the game, in the spotlight, in the middle, where you know how to deal the problem, whom to refer the patient, when to refer the patient, what to see, what not to see, what are the relevant points, what are the irrelevant points, how do you brief us, how do you lead your referring physician. So these are very, very important in the entire gamut of a valvular heart disease patient's journey. This would again be a very, very country-wise, prevalence of heart disease. This includes valvular as well as coronary heart disease, and you can see that in the extreme southern part of the African continent, countries like Botswana and Mozambique and South Africa, they have a high prevalence of coronary artery disease. It is it is primarily one because of the large amount of Caucasian immigrant population that are there, and two, um, probably they are genetically preconditioned or predetermined to have a little more incidence of coronary artery disease, not valvular heart disease. Right. So I like to call it the sub-Saharan challenge. It would be quite difficult to believe that the same problem today in Morocco, Algeria, Libya, or Egypt would be quite different from what it would be in sub-Saharan Africa. Having said that, at this point, we are dealing with a child that has been referred to us from Libya with almost end-stage heart-lung failure as she awaits a heart-lung dual transplant. And believe you me, I have had the opportunity of seeing all her reports only a couple of months back, which said that her pulmonary artery pressures were only about 60 to 63 millimeter mercury. Today, when she presented to our OPD yesterday, today we measured it at 130 millimeters of mercury at a systolic pressure of 100. So, from a systemic pulmonary artery pressure in 2 months or 3 months' time because of a sudden acute sickness, it has gone up to suprasystemic, and nobody could pick this up. So the child has landed up in India. The parents do not know what to do. We don't know what to offer them. So yeah, there are challenges in emerging countries in terms of heart failure management, and then the problem is severe. Coming to what would be the solution to tackling the problem, because no problem how big it is until we find the solution, there is no end to it. So I call it the four T's for Africa. Train the doctors, time the referral, treat the patient, and telemedicine is the way forward. So let us engage with the doctors in the African countries. They can come to us, do some observership. We can go do some cabs, let them operate with us, let them understand what it takes to be, a good cardiothoracic caregiver or a good cardiothoracic doctor in terms of managing these patients. A. B, we would request everybody there to have very timely referrals for us, so that when we have the patient, we can do something for the patient. Not that the patient comes and you're just waiting for him or her to die. Treat the patients. Treat the patient with whatever tools you have in hand. Penicillin is a globally accessible medicine, so you can put them on a penicillin prophylaxis once every third week. You can give them some anti-heart failure medications. You can put them on a little bit of diuretic to make their hearts a little better in terms of temporary functioning. And should all of these not be put together, or should all of these not be fitting together, telemedicine is always the way forward. Be in touch with one of us. We will be more than happy to guide you to how you should manage, stabilize, and then transport the patient to whatever facility you want to. So I would now open the house for any questions from the doctors, because I've said enough about valvular heart disease and how to manage them. So
Thanks, thanks, Dr. Bishu. While we open the house to questions, I
yeah,
would like to invite, like, there are few very experienced colleagues of yours from
okay,
that part of the continent. So, like, we have Dr. Hannibal, who is an
okay,
medicine doctor, but a lot of exposure to cardiology.
okay,
Since challenges are similar, like, I think
yeah,
they can share their perspective. Or we have Dr. Miriam, who has seen, the gaps in the healthcare, because a lot of your talk actually hit the matter at hand. A lot of it is around capacity building,
yeah.
training,
Until and unless you have
telemedicine.
trained manpower there, you cannot be claiming that referrals are haphazard. Referrals will be haphazard. Referrals will be streamlined only when we are doing maybe two camps in a year, not to earn a million bucks, but just to train the doctors. Maybe a
So,
couple of surgeries. That's about it. But spend a couple of weeks just training them. Just do
Dr.
a little.
Hannibal, it
Yeah,
would be, I mean, the discussion would be richer if you share your perspective.
please, sir. Please, sir. I'd be very very interested to hear your side of the story.
Yeah, thank you for the chance, Doctor.
Thank you, sir.
Thank you for the chance. Yeah, I think it was interesting, such a timely talk with Varun. We had this discussion as well. There is, as you rightfully pointed, a shortage of trained personnel that could give timely and appropriate treatment for patients with valvular heart disease. Since, for example, in Ethiopian's context, valvular heart disease associated with rheumatic heart disease is a leading cause of heart failure in our circumstance, and younger patients do succumb to it as things go by. There
Yeah,
is obviously within the health system structure, both as you're aware, the primary, secondary, and tertiary delays. One is the poor health seeking behavior and access to facilities results in primary delays on patients earlier presenting for the predisposing diseases and even the valvular heart disease as well.
yeah,
Secondarily, when they get to the hospital, getting to the right physician and even the accessibility of the physician always creates it. And tertiarily, as you rightfully pointed, that patients tend to not be on appropriate preventative therapies and subsequently uh, get in a circumstance that it becomes a bit more costly and much more devastating complications happen down the line, as opposed to something that could have improved the quality of life for such young people. So thank you for such a timely discussion. And hopefully this would be a platform in which through Jivo we kind of work in capacity building and I guess creating access to physicians in at least preventing the secondary and tertiary delays in the platform. Thank you.
thank you so much, sir. Thank you.
Dr. Miriam, we would like, I think you have seen decades of it, like, capacity building, like the AIDS epidemic, like you had shared in one of the talks. So perhaps you can share because as Dr. Biswarup and Dr. Hannibal pointed out, I think we at Jivo, like we are a very well poised platform with this access to excellent hospitals like Artemis to at least do some part of those four T's that Dr. Biswarup suggested:
Mm.
train, treat, like
You know,
including surgical
train,
help.
time, treat, telemedicine.
Yeah.
So telemedicine, more often than not, I mean, if you send me a query, you would see that I tend to give very detailed replies, so that the treating physician has understands a viewpoint. A. B. Sending us a referral does not necessarily mean that, we only want the patient in the country to treat the patient. Some part of the treatment, I at times would say that, why don't you put the patient on about 20 milligrams of furosemide twice in a day and see how he does in a month's time, get another echocardiogram or get another chest x-ray. Do very basic, because I had the fortune of being trained by one of India's first female cardiac surgeons from the early 1970s. So we were trained by madam to identify, deal, and treat heart diseases with the bare minimum investigation. So I tend to ask people some very basic questions. Why don't we get a chest X-ray? Why don't we get a repeat blood workup? So it is more important to engage. If you engage, I'm more than happy to do free telemedicine consults, give you a quick heads up as to how you should be treating the patient at that point medically for the time being to get him better in a better shape. Third thing is how you should, time the referrals, as to, you should not be afraid timing the referral. Referring somebody, shows down poorly upon us, or referring somebody means the person is going to get out of the country. Remember, at the end of every day of your clinical life, you have been significant only when you have made a difference to a certain patient's life. What today would be a $10,000 malady, tomorrow might become, a requirement for an LVED or an RVED and become like a $250,000 malady. It is only this afternoon I had written such an email for a 14-year-old girl, who comes from Northern Africa, asking for $250,000, even to begin treating her. She's in complete heart lung failure. Um, Fourth sibling to be, having hereditary congenital hypertension. Three of them have died. And you cannot just look into the parents' eyes and, see their pain. They are in tremendous pain of not losing the last child. So what do you do? This girl, referred maybe 5 years back, would have needed a straightforward lung transplantation as a child and go on to live a couple of decades of normal life. So that is how severe the timing of referral can make the difference. And she has been seen by doctors all this while. It is not that the family did never take them to a doctor or did never take them to any specialist. So she has been seen by specialists. She has been seen by people. She's had multiple, um, I don't know how to say it, but she's had multiple irrelevant echocardiograms that are completely irrelevant. So that should not happen today. Today, in the age and time of 5G internet connectivity, where anybody can see anybody in a fraction of a second, do telesurgeries, robotic surgeries from different
Yeah,
countries.
yeah.
Yeah,
Dr. Miriam, please
Dr.
go
Miriam,
next.
please go for it. Go for it.
Thank you. No, thank you, Doctor. I couldn't agree with you more, both you and Varun. I think obviously our doctors are online themselves, they can speak for themselves, but I know our systems are not even delivering basic health services here in Africa for the most part, for the majority of people. So sometimes we're even more challenged when we get complex cases like this, as you describe. So it's very understandable. But I think what you're proposing is that getting in touch for some mentoring or guidance, referral, even just a consultation is the minimum at least a doctor should be able to do. And we didn't even have those resources when I was interning in very challenging circumstances. So I actually envy the doctors of today that we have all these resources, we have Zoom calls and, But sometimes even that information can be too much. So you think you're doing the right thing when it's not necessarily the answer. The solution is not always on social media. So consulting with the practitioners is more experienced, like yourselves, is so important. And I think this is a wonderful opportunity for them to take advantage
Absolutely,
of.
absolutely,
Yeah.
absolutely. I mean, generations of doctors have trained from seniors, have trained from teachers. Um, when I trained as a medical student, almost now it's almost 20 years ago. There was barely or sparsely some Google, very limited mobile telephone internet access in the country, and I believe that was such a boon. That was such a boon. Today, with there is more disinformation or misinformation than information, so everybody is trying to treat everybody else with the help of some AI or some Google search or some of those things. People are putting people on expensive therapies based on latest expensive therapies without even doing basic diligence. People are being put on pulmonary vasodilators without even being on a trial of diuretics. So yeah, that cycle has to break somewhere.
No, so Dr. Biswarup, I just wanted to chip in here. So like
Yeah,
you have this is your third master class. So
yeah,
what we have done, we cannot solve everything, but at least a start. So this
yeah.
forum, the doctors, they get to interact with specialists like you every
Yes,
Sunday, different things. So at
yeah,
least that helps in understanding and something. But
yeah,
what was a very striking message for me, like at Jivo, what I was sharing, that on the African side we have institutions and doctors who are on a network,
yeah,
and like the training thing and this valvular heart disease, which
yeah,
is such a, I mean, which I mean, the one takeaway message was that if there are a lot of, I mean, even with the nursing staff, etc., if those kind of training and they are referring up to the relevant specialty, a lot of it can be detected in time, and that's what somewhat Dr. Hannibal also echoed. So what I was proposing was that right now, like we can go beyond master classes and think
yeah,
of, how we can benefit, with our institutional partners there. Right now, there are some, I mean, some of these audience, they own clinics and hospitals also, like they run, the people who are attending today, or they are key functionaries there. So maybe we can think at least we can make that difference so that the reach expands, and there becomes even I mean, within that referral protocol, that they go to their tertiary hospital first, and if needed, then they have a line of access to you. And sir, about the telemedicine that you mentioned, you made a very relevant point, and that's what Jivo Connect Clinic is. That today, everybody thinks like, evacuating to India or evacuating to Turkey, but the right answer is that the local doctor, local healthcare
evacuation is
system,
not the
and
answer.
local specialist
So
are together.
evacuation, yeah, we're talking about 250. I mean, it was only last week we tried to evacuate a boy out of Mauritius, and it was about 165,000 US dollars. So that is not the answer. The
No, no, no.
answer is,
Okay,
yeah.
so
So the
evacuation
answer
is
answer is somebody should have been in Mauritius a couple of years back, trained 10 local cardiologists to
correct.
deal with very simple problem in very simple way.
And there should be a structural mechanism that a cardiologist in
Yeah.
Mauritius or any other country, they have a regular schedule so that doctors like you and that local doctor, they can review and identify and do the joint consultation so that the patient has timely intervention and a path, whether it is being
Happy
done
to dedicate
locally.
a little bit of my time for maybe weekly or fortnightly consultations. Happy to travel, frill-free economy, live a very normal life for 17, 15 days, train a bunch of doctors in one specialty clinic as to these are the ABCDs of seeing a valvular heart disease patient. These are the ABCDs of reporting it. This is how you follow them up in the
We will,
community.
we
These are
will,
the relevant
we will work in
paperwork.
that direction, sir. We'll work in
Yeah,
that direction.
yeah,
With our because in this we have some of like emerging leadership of African healthcare present,
yeah.
thanks to them, and I think we would work in this direction because that's the answer. uh, Totally, when both healthcare systems are linked, African as well as Indian, then
Yeah.
probably the right answers would emerge.
And I have always said that, um, this comes from personal experience, that going to Africa to do camps, is not the answer, because that has been tried over the last 30 years by half a dozen people that I know. um, it does not work. Yeah, it is a financially profitable proposition to go operate 30, 40, 50 cases, come back with a reasonable amount of money. But 30, 40, 50 lives saved is not an answer where 30, 40, 50 million lives are at stake. Answer is
Correct.
training,
Yeah.
treating, timing. That's the answer.
And sir, I think that fits in the like capacity building, sir. What you're calling
Yeah,
is capacity building.
absolutely.
What the patient coming to India or we going there, that is just a patch on the
Yeah.
larger problem, patchwork on the larger problem. The issue is systemic. So I'm hoping that at least the doctors who are present here today, we benefit at least for Dr. Biswarup. So he's always very eager to interact and help. So we will discuss a lot more cases and a lot more patients around these can be benefited. So I think let's entertain a few questions also.
Okay. There is the chat.
No, no, no. I think no questions so far, but I'm requesting that you can
Yeah.
discuss any patient case or you can ask questions.
Yes, please do.
Yeah,
No,
the
no,
chat has been disabled, Varun, but I'm sure people
really?
can ask. Yeah,
Let me, okay, ma'am, maybe
yeah.
some setting. Okay, I am so sorry if somebody had highlighted to me. Maybe some setting error. I've enabled it. Please ask a question in the chat, or you can unmute yourself and ask a question.
I was just going to concur that the training, the what doctors proposed to come and take a 2 week time to do that intermittently would be that's the longer term solution, and that's really very good. Really appreciate that.
Uh, so please ask a question, Dr. Martin, Dr. Filmona. Sorry if you're facing issues with chat. I think there was an issue with some setting. I have changed it. You can type your question in the chat and you can ask Dr. Martin, Dr. Filmona, Dr. Coleman, Dr. Innocent, Dr. Jacob, Dr. Chileshe, Dr. Onona.
Yeah,
Uh,
may I say thank you for the
yeah, Dr.
very
Isaiah, please
wonderful.
go ahead.
Yes, may I say thank you for the wonderful presentation. I think it has been a challenge in our African side. Maybe apart from those programs of sending doctors for fellowship, 2 week stay, or even 3 months stay, will it be significant reduce some of the health-related problems? Maybe. Is it possible for Jivo now to get acquainted with our government systems in Africa? As for me, uh, I could wish we have a regular budget for different challenges in various places across Africa. If not budgeted and not planned, we will still be on the same
No,
problem.
Dr. Isaiah, I agree with you, and I think we can take this like how we can brainstorm around it, how we can do it more structured and more widespread. And after this masterclass, maybe sometime today evening or tomorrow, let's discuss this, like how we can present this proposition to the governments also. There's a question from Dr. Bills, how we can get close to Dr. Bills. I think this is your first masterclass that you're attending. So, as in the beginning of the event, I had shared a schedule. So at Jivo, we offer you two cases. Let's say you have a patient case and you want a joint consultation with the Indian doctor. So the first thing you do is we have a WhatsApp group with you. You share that information with us. Our team helps you collect the medical information and we document it. Then we share it with specialists like Dr. Biswarup, who reviews and they give their comment. We share with you. And basis your availability, Dr. Biswarup's availability, And it can be a different specialist. Like if I'm talking about cardiology, like Dr. Biswarup, and patients availability, we organize a consultation call like this on Google Meets or Zoom, or sometimes even on WhatsApp. So we do that. That's a regular process. What we have done in the last 2 months is that we have also started making this regular. So every month, like here, it's the beginning of April. So last week of April, right from 23rd to 28th, so we have pre-agreed slots from doctors like Dr. Biswarup and other specialists, and you can send patient information to us timely, and you can align them so that the patients get joint consultation with you and with the Indian doctor. Just for everybody's reference again, let me share the Connect Clinic schedule for April with you. So it's a very wide range of specialities. So we are covering spine and neurosurgery and infertility on 23rd of April. And the names of the doctors also mentioned, and it will be shared. It has already been shared with you, but since you are attending first time, my teammate Soumya will share it with you. Then for cardiology, we have this Connect Clinic schedule, which is telemedicine with Dr. Biswarup only, the one who is conducted the masterclass today. And if it is a pediatric cardiology case, that will be scheduled with Dr. Asim, who is his colleague from the same hospital. Dr.
Yes.
Asim heads pediatric cardiology, and Dr. Biswarup is about adult cardiology. Then for orthopedics, we have Dr. Rakesh Mahajan, and for sickle cell, we have Dr. Dharma Chaudhary. And for medical oncology, we have Dr. Neeti Raizada. And for surgical, we have Dr. Archit Pandit. Similarly, for liver disease, we have Dr. Ashish George. And for urology, we have Dr. Mohan Keshwamurthy. And a lot of these names, like Mohan Keshwamurthy, Dharma Chaudhary, Rakesh Mahajan, these are those kind of medical leaders, like Dr. Bishu fondly spoke about his teacher, like who was even a generation prior to
I would
them.
know. I would know Mohan Keshav Murthy for sure. I know Mohan Keshav Murthy. Yeah, he's
Yeah.
a very, very, very respected name in Indian neurology.
So these one many of these doctors are already established leaders or emerging leaders like Dr. Bisru. So a lot of your patients, like Dr. Bisru, Dr. Asim, they are the emerging leadership in cardiology and pediatric cardiology. And Dr. Dharma, Dr. Mohan Keshwamurthy, Dr. Neeti, they're well established. So the idea is that your patients, they benefit from these joint consultations. Specialist input comes from the Indian doctor. You are the local caregiver there. And this is how we benefit more and more patients. So now going back to the chat, so okay, wait. So okay, you have been trained in sir. Actually, telemedicine as an idea, it has been there for decades. So somebody would book, but what we as a healthcare company believe that if it is in a healthcare setting, I mean, in a telemedicine, anybody can go to Artemis website, any patient, and book their consultation with Dr. Vishnu. It's there. But the way we are operating is that building this bridge between the African doctor and Indian doctor. So it happens like normally you just there is no app for it. I mean, when Zoom and Google Meet they do the job, or even WhatsApp they do the job. So there's no need for app. So Dr. Bills, you get in. What we'll do is I'll have a conversation with you. My teammate Soumya will connect with you, and I'll explain how Jivo works. So basically, the telemedicine support that you're asking is structurally available in Jivo. So there are two ways scheduled. Every month there's a schedule. You can align your patients in that. Or if you want it early, you can share the reports, and based on, let's say, availability of doctors like Dr. Biswarup, your and your patients, our team matches the schedule and organizes this. So we
And we
regularly.
can we can also partner with some of the doctors who are interested as to image sharing today is a problem. So I get to see very rudimentary CT scans where you can see the bed sheet in the background or a kid playing in the background. So from that CT scan to interpret whether the person he or she needs a lung transplant is near impossible. So today in the age of DICOM imaging, sharing gigabytes of imaging takes minutes. So yeah, we can help them in this regard. We can provide them with our specific email addresses and stuff where they can just upload the thing in the Google Drive, share the email, and
No,
I
so
can,
we are helping. Dr. Vishnu, we are helping. I will need to give you some context. So
yeah,
every doctor, they have a
yeah,
assistant or a relationship assistant
yeah,
assigned
your
from
side.
Jivo. Sometimes even I act like that.
Okay.
Although I'm the founder, but we have to act like that because doctors need that support.
Yeah.
Everything is documented. We have a lot of Google Drive coverage. We
Mm.
we share with them the drive folders, they
Yeah.
document, and we share it with. You must have seen that all of our case file is very organized.
Yeah.
If
Yeah.
the
Some of the
patient
cases are
goes
really
there and
organized.
very organized structurally, what the complaints are
Yeah.
and the reports that are there. So we are hand-holding the doctors in all of this.
Yeah.
Like today is our 85th masterclass, third
Okay.
with you. So we are
Okay.
running a very comprehensive this knowledge building. And as you see, Jivo Current Clinic, like you were talking about telemedicine, we have gone into the next level. We have made it structural so that let's
Yeah.
say
I
a
keep
hospital like
visiting days.
let's say St. John's Hospital in Zambia,
Yeah.
so they have a telemedicine schedule, like a connect clinic with
Yeah.
Artemis, Fortis, and Max. And now these are the best healthcare brands in India, and with specialists like you. So we have gone that, and also because not every patient can wait till the end of the month. If there's an
Yeah.
urgency in thing, we organize it
Quick video
routinely.
call or
So,
quick session.
so,
Yeah.
so that is the idea, and let's hope to continue this. So we have another. Thanks for the presentation.
Thank you
Okay.
so much. Thank you
Okay.
very much.
Any more questions? Please feel free to type. And if you want to discuss any patient case which valvular heart disease that you're seeing, please feel free to discuss with Dr. Bishop.
I'm sure they will have your email address to
They
send it
have
across Varun. Yeah.
everybody has. So what we have is now we are building a doctor practice management app for like the Jivo cross-border collaboration. I think in 2-3 months we will release it. But every doctor on Jivo platform they have an individual WhatsApp group.
Okay. Yeah.
Everybody. So that communication, and of course, they have our email IDs and numbers also. So that
Yeah.
communication is never a challenge. And
Yeah.
all the masterclass, etc., all this coordination happens there.
Yeah.
So I'm just waiting. If anybody has any more questions, they may ask Dr. Biswarup right now, or they can write to us and we will share it with Dr. Biswarup.
Thanks so much. That's why. Yeah. Thank you so much. So, Varun and Paul.
Okay. Thanks, Dr. Anana. So I think we have also exceeded the time, allotted time. So if there are no further questions, and
We'll
we
close it.
can conclude this masterclass. And Dr. Hannibal, thanks for contributing also, because I think now our master classes should move that only the Indian expert sharing their experience to even African emerging leadership participating in it. We had a very interesting liver session on liver, where many a times the questions they were being answered by another DO doctors like Dr. Olyanka and Dr. Sebele from Zambia and Dr. Olyanka from Nigeria. So, Dr. Hannibal, I also wanted to discuss with you after this that how the training modalities that Dr. Visrup has proposed, how we can plug in into a larger program in Ethiopia, and taking help of your hospital there as the local anchor. So I think thanks, Dr. Bishrup. Your master classes are always very educative. I'm not a medically trained doctor, but I can follow, and your ideas are always worth implementing on. Sir, you're on mute.
Ideas are only worth when you're ready to do the hard work. When you're ready to travel, economy, lead a no frills life for 2 weeks and train people, that is when it works. Because if it's fancy, if it's me traveling business class doing 10 surgeries, it's not working. I can do 10 surgeries in 2 days.
Don't
Take
worry,
me.
sir. I will take you
That's
to
not the answer.
Addis Ababa is a beautiful city. Don't worry, sir. I'll hold on to you that. We'll fly economy because flight is the only option. But I think we will stay in student hostels.
Yeah.
We'll get to interact with
I have
students.
backpacked a lot of Europe on student hostels. I'm quite used to that idea.
Yeah, it will be I think you have even stayed at my institute in Karakoram Hospital next to the
I
hospital.
have checked
So I think we would we would have a good experience of
the
you know
long back, early 2000 should be.
yeah. Thank you.
Thank you so
I was
much.
there. I was a student. No, we had discussed. Your cousin was in Karakoram. I was in Aravali, next to us. Thank you. Thanks a lot for your time.
Bye-bye.
Thank you.
Thank you so much. Leave the meeting.